Welcome to Louisville Lectures, PEM Little Lectures.
Hello, my name is Robin Lund. I'm one of the third-year Pediatric Emergency Medicine Fellows. This is a brief little PowerPoint over suturing. So why do we sew? Why do we suture? There's two main reasons. One of them is hemostasis, and the other one is cosmesis. So if something's bleeding a whole bunch, and also if you need to improve the cosmetic outcome of a wound. There's some basics to remember. The most common complication of wound care is infection. For that reason, irrigation is the most important step for reducing infection. And the little adage I like to say is the solution to pollution is dilution. So what that means is it's really, really important to irrigate. All wounds are going to form some sort of scars, and it's going to take months for them to reach their final appearance. Some things in the history you want to ask about include the mechanism or how they got the wound. How old is the wound? Did it happen 2 days ago? Did it happen 3 hours ago? Are there any other associated symptoms? Is there any concern for a foreign body? And any sort of underlying disorders? Is this a person who's immunocompromised? And are they fully vaccinated? In particular, we're worried about their tetanus shot. Things on physical include where is the wound actually located? How deep is it? The length or the extent of it? And then also the condition of it. So is it clean? Is it super dirty? Is there irregular borders? And then you also want to do a functional exam. And things in the steps of wound repair include anesthesia, wound cleaning, exploration and debridement if needed, then picking out your suturing, doing the suturing, and then choosing your dressing type. So in RER, this is where our suture kits are located. There's a total of 3 suture stations that are located next to the fridge in the main ED. As you can tell, all of the drawers are labeled. Your first drawer has non-absorbable sutures along with staples, staple removers, and also your Dermabond or your Dermaflex, which is your medical glue. The second tray has absorbable sutures along with suture removal trays. In the third drawer, you have your betadine swabs, you also have needles, and you also have your bacitracin and Band-Aids, which are good for when you're dressing the wound. If you go down one more drawer, you're going to have your sterile gloves, along with Coban and some gauze. And then finally, in the bottom drawer is where you have the laceration trays themselves, some saline bottles. They also have the nozzles for the saline bottles and also some 4x4 cotton gauzes. This is what the bottom of the laceration cart looks like. In it, you can see the laceration tray itself. You also have your saline, you have your nozzles for irrigating, and then you also have the cotton gauze as well. The first step is to anesthetize the area. There's a couple different things that we do to do this. We frequently use LET, which is a mixture of lidocaine, epinephrine, and taptracaine. It's a topical anesthetic, and it needs to sit for about 30 to 45 minutes. This is great for uncomplicated facial lacerations, especially lacerations of the eyebrow, of the forehead, of the chin, as that skin tends to numb really well with LET. For areas that are a little bit larger or that don't numb as well, we can do injectable 1% lidocaine plus or minus epinephrine. Usually I order the intradermal variety and ideally buffered to help reduce the pain with injection. This can be given in 2 different ways. One of them is locally, meaning you inject around the wound, or you can also do a block for certain areas. If you're doing lidocaine, and this is typically you're going to be doing 1%, you can do about 0.4 mils per kilogram with a max of 30 mLs. If you're doing lidocaine with epi, you can have a little bit more volume, so you can actually do 0.7 mLs per kilo with a max of 50 mLs. Typically, they recommend you choose a maximum of about 80% of those doses. Also, you might notice there's sometimes people do 2% lidocaine. We typically stick with 1% lidocaine because there's a higher risk of toxicity with higher doses, and there's really not as much benefit beyond the 1% lidocaine. Remember, we don't want to use epi in the ears, nose, fingers, and toes. I would also say in the penis as well. After anesthetizing the wound, you want to give it some time to take effect. I would give it at least 5 to 10 minutes because the cleaning itself can actually be painful. So you want to work on cleaning and irrigating now and make sure there's no foreign body. 95% of glass is actually radiopaque, so x-rays are a great way to do it. You can also do ultrasound to verify for foreign bodies. If wanted, you can also cleanse the periphery to remove visible contamination and dried blood. However, that alone is not sufficient for wound preparation without irrigation. Most people use an iodine solution for cleaning the periphery. And then you also want to irrigate the wound itself with normal saline using the pressure nozzle that I showed you earlier. Remember, the solution to pollution is dilution. The wound just prior to repair should look fresh, pink, maybe slightly bleeding or slightly oozing just a little bit. Now, here comes the part that most people struggle with. What type of suture? Frequently, you're tending asked what suture, and you say, well, whatever you want. And that's a great answer, but it's important to know what sutures we pick and why. So there's 2 main types of sutures. There's your absorbable and your non-absorbables. Some easy ways to keep them apart: absorbables are the ones that are going to dissolve, and so you don't need to have a follow-up appointment to remove them. These are typically flesh-colored, and some examples of these include fast-absorbing gut, chromic gut, or vicryl. On the flip side, you have non-absorbable sutures. These are the ones that are going to need a follow-up appointment to remove the actual sutures. These are great for high-tension areas, so frequently on extremities, and these are also going to be non-flesh colored. They're frequently black or navy in color. Some examples of these are ethylene and proline. What about what size? So you might hear things like 5-0 or 3-0. The larger the number is a smaller suture. The smaller the number, it's a larger suture. So these pictures came from our laceration carts, and here you can tell this is our first drawer, and this has your non-absorbable sutures. You can see that we talked about the ethylene, which is a nylon suture, and you also have proline in here. These are some absorbable sutures, and as you can tell, there's vicryl, chromic gut, and there's also fast-absorbing gut. We tend to use a lot of fast-absorbing gut here in our emergency department. As we talked about, size matters. So as you can tell on the top, you have 6-0 versus 3-0 on the bottom. The 6-0 is much skinnier than the 3-0 suture. So you would use things like 6-0 on wounds that don't require as much strength, but you'll use something like 3-0 or 4-0 for things that have higher tension and are going to need that stability to pull the wound closed. So we frequently use absorbable sutures, as they can have the same cosmetic outcome as non-absorbable sutures for superficial skin closure of the face. This picture is taken from a book located in the ER, and it talks about different areas and what types of suture are recommended. So in the face, you'll notice that on the alternative side, you're going to have 5-0 fast-absorbing gut. That's a pretty good choice to use. We also sew the arms and the legs quite a bit, and these I typically do 4-0 nylon, which is 4-0 ethylene. People also want to know, how long do you need to leave sutures in? So obviously, if they're the absorbable sutures, you don't have to get them removed because they're absorbable. That being said, sometimes they have trouble dissolving or absorbing, and they might need help at a follow-up appointment. For other wounds that have non-absorbable sutures, here are recommended days prior to removal. And remember, if you're on a joint or extensor surface, you want to add a couple days to help promote the healing. Now, let's take a look at how to actually sew. These are the typical supplies in your suture kit. You'll have 2 sets of forceps, one of which has teeth for touching the skin, and the other one is flat for grasping the needle. You'll also have a pair of scissors for cutting your sutures. You'll also have 2 different needle drivers, one of which is curved and the other one is flat. For your first step, you're going to load your suture with your needle driver, and then you're going to take your toothed forceps to elevate the skin so you can go in at a 90-degree angle. And as you can tell, we're trying to go in at a 90-degree angle to help reduce the risk of tissue damage. You want to be careful not to put too much pressure on the epidermis, as it can cause pressure injury with compression of the skin. You're going to want to insert your needle at a 90-degree angle into the center of the wound, and once it comes through, you're going to grasp your needle and pull it out. You will then reload your needle and put it again through the opposite side of the wound, again trying to go at a 90-degree angle. As it comes out, you're going to grasp the needle and pull it through. And as you can see, you're going to keep pulling your suture through until you have a small tail, but a tail that's still long enough that you won't accidentally pull it through a wiggling child and lose your stitch that you've made. As a safety tip, you want to go ahead and try to secure your needle by covering it with your curved hemostat, so that way no one gets poked. You can then put this on the side and out of the way of the child and of the staff. Now that your needle is safely covered, you're going to go ahead and draw 2 loops around the instrument and grab the distal end of your short string and pull to bring your suture nice and down. Now we're going to do that same thing again with taking the long loop, doing a loop around it and pulling your short string. And now you notice the short string is on this side of the patient and the long string is on the other side. So now you're going to put your loop on the long side and pull your short string so that your short string is now on the opposite side. And again, for reiteration, we're going to do the exact same thing, where we're going to grab the long string, do 1 loop, grab our short string, and they'll change places again. Once you finish this, you're going to take your scissors and lift up on the suture and cut to create a nice little tail for a simple removal, but also not too long that it disturbs the patient.